Hello, everyone. Welcome to our presentation entitled Barriers and Facilitators to PrEP Access, which are results of an integrative review. My name is Jose Tovillo. I'm a PhD student at the University of Alberta in the Faculty of Nursing. I'm currently doing my research on the experiences of young men who have sex with men in relation to their PrEP access in Canada. I also would like to acknowledge that this work was done with Dr. Vera Caine, who is a professor at the University of Alberta Faculty of Nursing.
Thank you, Jose. My name is Thomas Trombetta. I work at Freddie. We are a PrEP service provider that is currently active in Alberta, Saskatchewan, Ontario, and Quebec. And I work as their community manager, as well as doing some research with Jose and Dr. Vera Caine around PrEP barriers and facilitators. Very excited to be here today.
Okay, so just to give you a background of why we did this study. So according to several researchers, the rate of HIV globally is still increasing despite the different well-established prevention and diagnostic strategies. And one of these strategies is PrEP, which is a highly effective medication used to reduce the risk of HIV acquisition in populations that are at high risk of contracting the virus. So PrEP was approved by the US FDA in 2012, and in 2015, the World Health Organization actually released a treatment guideline that allowed or recommended the use of PrEP for populations at risk for HIV infection. However, we also found that there remains a lot of barriers to PrEP access among different populations, and there are also facilitators to access.
So in terms of the purpose of this review and our goal by conducting this review was to look at these barriers and facilitators to PrEP access as it relates to PrEP uptake, particularly among different community settings. So we wanted to identify the barriers and the facilitators so that we can come up with information in a study to inform stakeholders and decision makers and help hopefully make some policy changes and some service changes around PrEP uptake and PrEP access, ultimately trying to favor those who are at higher risk for HIV and those who find themselves at the most need for PrEP as an HIV prevention strategy. So this review is really guided by the research question in terms of what are the barriers and facilitators to access HIV pre-exposure prophylaxis amongst different communities at higher risk for HIV.
Okay. Thank you, Thomas. And to answer our research questions, so we conducted an integrative review, which is a type of review that allowed the inclusion of different methodologies. So we included quantitative and qualitative research. And again, for inclusion criteria for this review, again, primary qualitative and quantitative studies with varying designs. For language, we chose English studies, so it's easier for us to do the extraction and analysis of the data. We also included studies that were published between 2012, which is the year that PrEP was approved, and December 2019, which was the time that we did the review. We didn't exclude any countries, so we included all of them, and we included all populations as well that are seeking access to PrEP. So with the help of a librarian at the University of Alberta, we searched different databases that are listed in this PowerPoint here, like Medline, Embase, CINAHL, ProQuest. We also searched different gray literature and other sources like Google Scholar, Science Direct, different websites like the World Health Organization, UNAIDS, and Caine, and the CDC, just to make sure that we didn't miss anything. So all in all, we got 2,880 articles from the initial search. And after removing the duplicates, we ended up with 1,111. And then so we went through the title and abstract for this one. We did screening, and then we ended up with 276 articles, which we included for our full text screening. So we went through all these articles, and at the end, we ended up with 48 final articles that are included in the review. So our findings here, so we identified 11 different populations within the 48 studies that were included. So this included the general MSM, which is 16 studies, young MSM with 5 studies, MSM involved in sex work with 2 studies, incarcerated MSM with 2 studies as well. Also, we found 1 study that talked about transgender men, 5 studies that talk about women in general, women experiencing intimate partner violence with 1 study, transgender women with 4, people who inject drugs with 1. We also found 2 studies with homeless young adults and 9 studies that are unspecified. So it's a mix of different samples, so that's general population. We also found that most of the research involves the MSM population, as you can see with the numbers. So I'm going to discuss today the different barriers and facilitators that we identified. So we identified different themes across the different studies, and then we came up with themes for the barriers and themes for the facilitators. So for the barriers, so we have stigma-related barriers, which include PrEP-related stigma, shame, and confidentiality. For example, MSM and young MSM reported that taking PrEP comes with the stigma that they are taking the medication because they are having promiscuous sexual activities. On the other hand, incarcerated MSM experience PrEP-related stigma and discrimination because of their histories of substance use, poverty, unemployment, and incarceration. Shame is also another barrier related to stigma. For example, women and transgender women reported shame because of the hostile reaction and disapproval from family, friends, and their partners. And lastly, there are issues of confidentiality as well. For example, MSM engaged in sex work reported that they're not comfortable disclosing information about their sexual behaviors and to their partners due to breaches in confidentiality. For socioeconomic barriers that include cost, geographical and physical access, and low socioeconomic status and lack of healthcare insurance. So cost is a concern for MSM in general, for young MSM as well, and especially for homeless young adults. Geographical and physical access to clinics providing PrEP services is also a barrier, mostly reported by MSM and women that are especially those living in rural communities. Also, transgender men and women reported that being in low socioeconomic status and lacking financial security and stability negatively affect their ability to access PrEP, while the lack of insurance among people who inject drugs, for example, and the general population prevents them from accessing PrEP when they need it. Medication-related barriers, so that includes side effects, issues related to PrEP compliance, adherence, low risk perception also is one, lack of trust in the medication, and doubts related to the efficacy and effectiveness of PrEP. So for example, several populations reported that side effect is one of the reasons why they will not take PrEP. So that's including transgender women and young MSM. Those MSM engaged in sex work will not take PrEP because of side effects as well, and that could affect their work. Also, it's a problem for some people, compliance and adherence to the medication, especially for, let's say, transgender women who already are taking numerous pills and are going to different appointments. On the other hand, thinking that having a low risk of contracting HIV is a reason not to access PrEP among a number of groups, so that's including MSM who are using condom and who are in a monogamous relationship. The next barrier that we identified are relationship barriers. So that's included confidentiality and problems with their partners. So for example, young men who have sex with men reported that their partners would perceive them as if they found to be on PrEP. That could cause problem in their relationship. Another important one is women reported that there's a need to have their male partner play a part in the decision-making regarding taking PrEP, while others reported upsetting their partner when they find that they are on PrEP. Some women also reported accessing PrEP could be an indicator and reason for distrust in their relationship. Especially those women who are experiencing intimate partner violence. And then the last barrier that we identified are the healthcare provider barriers. So this included those providers' lack of knowledge about PrEP and medical mistrust. So for example, some MSM reported lack of access to competent PrEP providers. Other MSM reported concerns about frequent medical visits and checkups required. Some women reported that some healthcare providers do not have enough knowledge about PrEP, and they feel like they have to educate their healthcare provider instead of the provider educating them. Also, we found that some women and transgender women has medical mistrust issues as a barrier to PrEP access. So for example, we found that Black women reported higher mistrust towards their healthcare providers than Caucasian women. And also transgender women reported significant high medical mistrust due to experiences related to transphobia and providers' lack of trans competent treatment. And then with that, we also identified different facilitators. So we have socioeconomic facilitators, which include cost and availability of health insurance. So most MSM reported that they would access PrEP if it's subsidized or free. And this is the same with transgender women, we found. In addition, the availability of healthcare insurance that will cover the cost of PrEP is also a facilitator, especially for young men of sex with men, for MSM engaging in sex work, and for the general population. Also, YMSM believes that having healthcare insurance will allow them to access primary healthcare provider, which is crucial in PrEP access and use. For healthcare-related facilitators, we identified healthcare providers' availability and availability of and access to healthcare services, also availability of support that promote PrEP access. Facilitators are also the ability to disclose information and having a trusting and good relationships with the healthcare providers. So for example, MSM engaging in sex work reported that the availability of a competent and knowledgeable provider is a significant facilitator for them. Women highlighted the importance of having trusting and good relationship with their healthcare providers. We also found that the availability of access to PrEP services is an essential facilitator to access. So for example, for homeless young adults, they reported that having free access to healthcare services like PrEP services is a significant facilitator for them. Also, MSM and MSM engaging in sex work reported that the availability of support from the government, from various organizations and staff also promote PrEP access. And then we also have information-related facilitators. So this include knowledge about PrEP and having a trusted source of information. So for example, Black women found that, or Black women reported that if they are provided information about PrEP, their interest to take the medication became significantly higher. Another study found that transgender women who were provided education about PrEP considered taking PrEP as an HIV prevention method. And that's the same for YMSM and women who showed interest in accessing PrEP based on the information that they obtained from their clinics, from healthcare providers, from print ads, from social media, and from peers who had positive experiences with taking PrEP. Our second to the last facilitator are the medication-related facilitators. So this include, like having minimal to no side effects and knowing that PrEP actually works. For example, women and people who inject drugs reported that they would like to take the medication after learning that PrEP has minimal to no side effects. MSM in general indicated that being educated about PrEP and its efficacy helped them or with their decision making. And then lastly, YMSM reported that they would take PrEP if they think that they are at higher risk of contracting HIV, secondary to having multiple sex partners or substance use and having an HIV positive partner. And then the last facilitators are those relationship facilitators. So this includes safe sexual practices while on PrEP, support from their partner and family, and having a sense of empowerment. So for example, women indicated that knowing that PrEP allows them to have safer sexual practices encouraged them to access PrEP. For men who have sex with men, PrEP adds an additional layer of protection in addition to condom use. Women also felt safer being on PrEP, especially when having sex with a man with their partner who doesn't want to use condom or someone who is HIV positive. Being on PrEP also provides a sense of empowerment, especially for transgender women and women in general. And also like having that support from family and friends added to their willingness to take PrEP. So these are the main themes that we identified in terms of barriers and facilitators, but we also would like to highlight that there are other barriers and facilitators that are specific to a specific populations. For example, MSM reported that LGBT shaming is one of the barriers to PrEP access. They reported that some members of the LGBT community shame them for being on PrEP, unfortunately. Some MSM also reported fear of contracting STIs, like they're not using condom and they're only using PrEP. On the other hand, for example, transgender men and women also experiences specific barriers to PrEP. So for example, transgender men reported a lack of studies regarding the safety of PrEP done on their population, the reaction of PrEP with testosterone, and the option of using IUD or intrauterine device versus PrEP. Transgender women reported a lack of transgender women representation in PrEP campaigns, and also lack of information about the safety of taking PrEP while on hormonal medications, which hinders their access to PrEP. And then some population-specific facilitators, for example, incarcerated MSM reported that having a PrEP prescription provided to them and beginning to take PrEP prior to their release from the facility facilitates access to PrEP. Women identify the potential of conceiving an HIV-negative child despite having an HIV-positive partner is a facilitator to PrEP access. And transgender women also reported that like having appropriate information regarding the safety of taking PrEP while being on hormones, and also, the use of technology and information through social media help them or encourage them to access PrEP. Back to you, Thomas.
Thank you, Jose. Now we're going to be talking a little bit about some gaps in the research and the literature that we have found, as well as finalizing our presentation with some potential interventions, recommendations, and acknowledging some limitations that were encountered. So to start off, some of the gaps in research really included a gap in PrEP research as it related to PrEP uptake and PrEP access across different communities. There was a lack of intersectional analysis that considered multiple minority stress factors acting simultaneously. So that is, we saw that a lot of the studies did focus on men who have sex with men and intersections that involve that population. So young men have sex with men have sex with men who are in sex work, incarcerated men have sex with men. However, other populations like people who use drugs, trans and non-binary people, African, Caribbean and Black communities, Indigenous people, people who use drugs, all of those communities were looked with less focus and less attention to that intersectional part of things. There was also a lack of community-based research practices, which meant that a lot of these populations at higher risk of HIV were not necessarily perceived as active agents in matters as they related to their own health and as decision makers in matters that related to their own health. So it was usually those studies perceived those data samples as data samples rather than communities with a high knowledge, interest, and understanding of what are their health needs and how to address those health needs. And lastly, in terms of the gaps in the research found, there was a lack of assessing the impact of peer support involvement and public health measures to promote and to improve PrEP access. So really people with the lived experiences, people impacted by HIV and at a higher risk for HIV were also seen as left behind within this PrEP process and uptake and access initiatives, as there were very few peer support initiatives available and peer support initiatives that did value the lived experiences of people within this medical support setting. And those were perceived as being highly valuable to interact with somebody that has perhaps a similar identity, similar life experience to you, offers a huge opportunity for us to understand health matters in a different lens, lens with less stigma, less historical mistrust as well. Now, when we're talking about potential interventions and recommendations, we're trying to consider what are some ways to move forward that are going to allow us to increase the uptake of PrEP by populations at higher risk for HIV. And I think the first step is to dismantle that idea that PrEP is a gay-only drug or a gay man's drug. So although gay men in Canada represent about half of the new yearly HIV infections that are detected, PrEP can be a helpful and powerful prevention tool for many, many other populations that were mentioned. So when we create this idea and this narrative that translates into media, that translates into policy, that translates into this visibility only for one community, other populations start perceiving it as not for them, which becomes, I think, it has very strong public health consequences and impacts when that starts to be perceived as for one risk group only. I think the potential and the power of this prevention strategy gets minimized by the narrative that's built around it. And that's certainly something that the lack of studies, including other populations, contribute towards that narrative, unfortunately. So I think the first step is to understand how different populations also can benefit from PrEP, besides the one that we have been seeing across over and over different platforms. We also need further research and public health measures that prioritize on a complex understanding of identity, power, access, and the impact that that has on sexual health services. A lot of people are afraid to visit those centers and to access STBBI treatment, testing, services because of mistrust, because of shame, and because of those power dynamics that have to do with their sexual and gender identity a lot of the times, or with their ethnicity, or with their ability. So I think that an anti-oppression framework is really, really deeply needed for us to understand that these social determinants of health that are identity-based, as well as giving us the framework as how we move forward and create that trust and create environments so people are going to thrive and be able to access treatment and services for prevention that are appropriate for them and that reduce their specific harm. The analysis of the communities that we have also shown in research, like I said, is very minimal. It is largely around MSM. So again, that visibility within research, I think, is a huge first step towards increasing the access of different populations to PrEP. As well as a perspective of community-based research, right? We can't understand and perceive these communities at higher risk of HIV as stagnant or as impartial and inactive at the face of being at higher risk for STDBIs. These populations have a very strong agency, understanding, and power when it comes to their own behavior, when it comes to their own health. So I think that when we are perceiving and looking into further research, we need to make this very clear in our understandings of the populations that we're studying, that they're agents of their own health, and we need to make space for those agents to partake in decision-making and to partake in the service provision, because otherwise we're going to continue isolating the people that we're meant to be talking about and that we're meant to be supporting. So again, this anti-oppression framework comes up to me and to the team as a very strong strategy that will allow us to critically study different power dynamics involved in medical provision and service provision within healthcare access. And this would, I think, greatly enrich the research and public health measures that we take to understand best social determinants and to understand best access challenges and facilitators. And lastly, within our interventions, there is a need for more research and studies that look into peer support and to look at the value that peer support has into not only building capacity amongst people that have lived experience within homophobia, transphobia, drug use, sex work, monetize those communities and create those support settings, but also ensure that we are providing care in a way that is contextual, that speaks to the communities that we're talking to, and also in a way that respects the fact that lived experience is an invaluable part of care. And having that connection with peers is really a way to combat isolation and to combat the stigma that is very often included within sexual health discourses and sexual health narratives, especially amongst queer and trans populations. So that concludes a little bit regarding the interventions and recommendations. Essentially, I think we're speaking about diversifying the populations we're talking about to include more populations at higher HIV risk, looking at these populations as powerful agents within their own health, as well as leaders, but also understanding them as in more complex ways than we're used to understanding them, and making sure that we're studying the multiple stress factors that are associated with different identities that have historically been oppressed. And when we talk about the limitations of the study that we have conducted, it was mostly regarding the heterogeneity of studies and the inability that we had to pull some data to make it difficult to broaden the recommendations, to make these recommendations more generalizable on how to address these barriers and these facilitators. So because of the lack of quality assessments and integrative reviews, studies with poor quality were potentially not excluded from this review. So really understanding that there must be a more complex and a more wider pool of studies for us to pull to make more solid and concrete interventions and recommendations that are more widely applicable. And I think that concludes my part. I wanted to spend some of my last minutes thanking my co-authors, Jose and Dr. Vera Caine, for a wonderful experience doing this research. And I want to encourage everyone in the audience to reach out if you have any questions. And if you want to speak further about questions, collaborations, partnerships, I want to thank everyone again for attending and for being involved in this work.
Okay, thank you so much, Thomas. So for our last slide here, we just want to show that, yep, thank you. So yeah, so we would like to, like what Thomas said, if you have any questions, we would like to hear them. So feel free to email me at josebenny@ualberta.ca, or reach out using my number in the slide, and I will connect with my team to answer your guys' questions. We also would like to to say that we don't have any conflict of interest to declare in this presentation or in this review. And of course, we would like to thank Freddie, especially Leah Mackenzie for the photos that we use for this presentation. So again, thank you, Thomas, and in behalf of Thomas and Dr. Vera Caine, thank you again for your time. Thank you for listening to our presentation, and yeah, have a wonderful day.
Thank you.